Sir, for this invitation. Really honored to be here, to be part of these sessions. Um, so, can all of you see my slides?
Yeah, we can see your
Yeah.
slides and we can hear you very well. Please go ahead.
Yes. Okay. So I'm not going to spend a lot of time. This being a lung cancer forum, so we all know lung cancer is a poster child of precision oncology. So what we know in lung cancer today, we have nearly 14 biomarkers, primarily broadly classified as somatic biomarkers and immunotherapy biomarkers. And these are the markers as listed out here. And how did this happen? It has been getting added in the last 5 years or so. We have been having successful clinical trials which have proved the efficacy of some of these targeted drugs, and hence these biomarkers came into existence in standard of care. So, what are the methods that we use to detect the presence of these biomarkers? The most common ones are real-time PCR for EGFR, then Alkan-Ross by IHC, and so on and so forth. Fish fish method for ROS1 and MET amplification. For monitoring, we use ddPCR. So when one has to do multiple assays from a single tissue, one has to know where to stop or how to make it most beneficial for the patient, considering true cut biopsies are the standard diagnostic material that you get from a non-small cell lung cancer patient. So then we have moved on now pretty much to targeted NGS, where we look only for hotspot mutations. So what is beyond targeted NGS is comprehensive genomic profiling. Where is the value addition coming from comprehensive genomics? Is these biomarkers, primarily the microsatellite instability and tumor mutation burden. These are genomic signatures which could not be addressed by short hotspot panels as mentioned above, these somatic biomarkers. Definitely they require a larger panel to address these or calculate the value of these biomarkers. So here we stand with NGS being beneficial as compared to single gene testing, where you not only save the um, amount of tissue, time, and also the cost by doing sequential testing, you are getting your benefit of complex genomic alterations. So just to go back and see what do we know in terms of the landscape of non-small cell lung cancer. Figure shows here with most of the targeted drugs that has been approved, which are biomarker driven. I wanted to draw the attention here to 31% of unknown mutations. So can we understand something in this domain? What can we add as a value added benefit to this particular spectrum, where can we discover new markers, can we look at new ways of targeting these patients? This is one thing why a comprehensive genomic profiling would add value by NGS method. But in not only that, in a routine clinical practice, it helps in saving time and also preservation, as I mentioned above. The con here is the turnaround time, which is on an average 3 weeks in most of the laboratories. So what we did at 4Base Care was we tried to ask the following scientific questions. What is beyond the approved targetable mutations in non-small cell lung cancer? Can CGP help or provide new promising biomarkers? Is Indian cancer genome different from others, particularly the non-small cell lung cancer? Towards this, 4Base Care got the 4Base Care was fortunate to be part of the Illumina Accelerator grant, which was approved in the year 2019, and it was a massive collaborative effort between 4Base Care and several academic institutions like Tata Memorial Center, ACTREC, AIMS, and Shankara Hospital, Yenapoya, Fortis, Yellow Ribbon, and Sir Gangaram Hospital. Thanks to all these collaborators, particularly Dr. Kumar Prabhash, who has been the primary driving force in these collaborative associations, and we could profile nearly 1,500 cancer patients for whole exome sequencing and transcriptome sequencing. The outcome was we could derive the most common mutated pathogenic mutations, roughly around 1200 genes across multiple cancers, and this is the panel. Having said that, we got full hands-on experience and a lot of skill set being developed in processing whole exomes and transcriptomes. We validated these two assays, the exome sequencing, transcriptome sequencing, as well as the targeted panel that we derived from Indian patients for clinical applications in routine practice as per the CAP and NABL guidelines. Beyond that, we also have an offering with Cellworks to understand the AI-based prediction. Now, just shifting gears, what are the key highlights of this research that we did on 1,000 plus patients, 1,500 patients? So I'm just going to quickly go through some of the important highlights. So it is still a lot of things to learn from this mutational spectrum. What we try to address is the heart of the main cancer cells function lies in cell cycle proliferation, and who are the feeders for this? Primarily, these are the pathways who feed the signal to the cell cycle control. So we try to look at all these pathways. What are the genes which are mutated in these cancer patients? And today's interest being non-small cell lung cancer, I'm just presenting here some of the highlights from 156 lung cancer patients, non-small cell lung cancer patients, who were profiled by whole exome analysis. I've kept the transcriptome aside. I would address that in a different forum because we had quite a few things to address here. So what are the pathways that we primarily looked at? Receptor tyrosine kinase, DNA repair, chromatin remodeling, cell cycle signaling, MAP kinase, and beta catenin slash Wnt signaling pathway. There was a reason behind looking at all these because some of the drugs, though not approved in non-small cell lung cancer, they are approved in other cancer types. Probably this would provide some of the leads for future design of clinical trials. So if you look at the proportion here, receptor tyrosine kinase mutations contribute nearly 37% of the total mutated contribution of non-small cell lung cancer. We do have a significant proportion, roughly about 4% from beta catenin, which is not at all well addressed even across cancer types. MAP kinase pathway is contributed by roughly 7%. Most of these pathways do crosstalk. However, having said that, particularly the receptor tyrosine kinase and the MAP kinase, but I will show some of the genes that are significantly, subclassified into the different bins here. Then cell cycle signaling in chromatin remodeling is very well addressed and has been well studied in leukemias, but when it comes to solid tumors, we are slowly understanding where we are in these genes, this class of genes, and how they have been part of the pathogenicity associated in solid tumors. And of course, the DNA repair pathway, which is primarily revolving around the PARP inhibitors. So receptor tyrosine kinase pathway, the following are the genes which we quickly looked into to see what is their contribution in these patients whom we have looked at in this profiling. So EGFR stands out to be the highest, and NF1 is part of again the MAP kinase pathway. RET kinase domain mutations here, and then FLT4 is also mutated in many patients, followed by FGFR3, FGFR2. And ROS1 and ALK are contributed by patients who were earlier EML4 ALK positive or RAS1 positive with kinase domain mechanism of resistance. And we also found some ERBB2 insertions, FGFR4 and others. So this is just to show where we stand in terms of the drugs that we have in receptor tyrosine kinase. And then with regard to the DNA repair pathway, what we see here is roughly BRCA1 found to be significantly mutated, followed by ATM and BRCA2. Then we also had KEAP1, MLH1, MSH6, but then we couldn't find many other DNA repair biomarkers being significantly mutated in this particular cohort. Then this is chromatin remodeling. Essentially, we looked at DNMT3A, TET2, and other biomarkers which are when they get mutated, it affects the epigenetic modification in most of the cancers. And having said that, these are the drugs that are available in clinical trials or they are approved in other cancers where there is a significant potential to look at particularly the ARID1B or TET2 mutations. Then coming to the cell cycle signaling, CDKN2A, we do know from many comprehensive genomic profiling that CDKN2A is mutated in many of these lung cancer patients. But then we wanted to look at other serine threonine kinase homologs, STK10, STK16. These are something new that we are finding. And then the CHEK1 and RRM1 mutations are also present, which has an indirect indication to cytotoxic and cytostatic chemotherapy. And of course, there were a few mutations being contributed by CCND, cyclin dependent kinase family. There were a few patients who were contributing with the aurora kinase activation also, which is an upcoming biomarker where clinical trials are available. Then coming to the MAP kinase pathway, we wanted to be very, very focused on EGFR and its downstream driver mutations. How many patients among these 156 patients who got mutated is what is being shown here. And then on the right hand side, we have the potential drugs. And with regard to Wnt or beta catenin, which is